Okay, we are live. All sergeants at this time, will you please start your recordings?
According to the computer, all set.
Thank you.
All recorded and rolling.
Thank you.
Backup is rolling.
Thank you. Sergeant Sadowski.
Good morning, and welcome to today's remote New York City Council hearing of the Committee on Mental Health, Disabilities, and Addiction. At this time, would all council members and council staff please turn on their video? To minimize disruption, please place electronic devices on vibrate or silent mode. If you wish to submit testimony, you may do so at testimony@council.nyc.gov. Once again, that is testimony@council.nyc.gov. Thank you. We are ready to begin.
Chair Lewis, whenever you're ready.
Hope you guys can hear that. Good morning, everyone. I'm Councilmember Farrah Lewis, Chair of the Committee on Mental Health, Disabilities, and Addiction, and I'd like to thank everyone who is joining us today for this remote hearing. I would also like to welcome members of the committee and council members who are present. I see currently council members Riley, Cabrera, and Borelli. This morning, we are holding an oversight hearing entitled Access to Mental Health Care in Communities of Color in New York City today in the year 2021, more than a year into a public health crisis that has worsened the mental health of nearly every person in this city. It is extremely difficult to find affordable, comprehensive, immediate, and culturally competent and accessible mental health care if you are a person of color. So I'll reiterate. If you are a Black, Brown, Asian, or another New Yorker of color, you are more likely to find yourself living in a mental health care desert. A mental health care desert or mental health care professional shortage area is a community where residents who need mental health services outnumber the providers who are available to serve them. For example, in the Bronx, 91% of residents insured by Medicaid, most of whom are Black, Brown, and low income, live in a mental health desert. Even for those that do not live in a mental health desert, communities of color in New York City are also far more likely to be under and uninsured than white communities, which automatically decreases access to affordable mental health care service. This is because mental health providers do not accept insurance at all. And although 90% accept private insurance, only 71% of providers accept Medicaid, and 85% accept Medicare. And even for New Yorkers of color with insurance that live in a community with mental health providers, it is difficult to find mental health providers with language skills, cultural sensitivity, who represent the diverse populations of New York City. According to the American Psychological Association in 2018, about 86% of psychologists in the United States workforce who were white or fewer than 15% were from other racial and ethnic groups. So I'll repeat what I said before. If you are a person of color in New York City, it is extremely difficult to find affordable, comprehensive, immediate, culturally competent, and accessible mental health care. This issue is not new. It is extremely complex and not easy to solve. This is a problem that has been created by generations of federal, state, and city negligence of our communities. To start, Medicaid pays rates that disincentivize even the most well-meaning providers. According to a Medicaid to Medicare fee index, which measures each state's physicians' fees relative to Medicare fees, in 2016, New Yorkers in a Medicaid program pay physicians' fees at 56% of Medicare rates. More specifically, New York's Medicaid program paid primary care physicians at 44% of Medicare rates. That is definitely unacceptable. Further, the shift from fee-for-service to managed care has left too many community-based organizations unable to cover their expenses, unable to receive reimbursements for their services, and unable to negotiate livable wages for their practices. That also is very unacceptable. Additionally, insurance networks for mental health providers are far too small. A 2015 survey found that people were far less likely to find or use an in-network mental health provider compared to other types of medical specialists. And finally, and perhaps more disturbingly, mental health parity, meaning that health insurers apply similar processes and restrictions for treatment and coverage of mental health and substance use disorders as they would for medical and surgical benefits. It has never been fully realized here in New York, leaving providers with low reimbursement rates and very difficult survey of state efforts to ensure parity when it comes to behavioral health insurance benefits. New York City has received a failing grade on this. So what are we gonna do about it? And what are we gonna do to ensure livable wages for mental health providers? What are we gonna do to advocate at the state and federal level to correct these problems? What are we doing to allow access to the next generation of New Yorkers of color to educational opportunities, mental health trainings, and graduate degrees? What are we doing to address stigma that may prevent New Yorkers in our most vulnerable communities from accessing care? And what are we doing to address the existing gaps in care throughout New York City? So I'll go on to share some sobering statistics. In 2017, 76% of US-born Asian American Pacific Islander New Yorkers with depression reported that they were at a time in the last 12 months when they needed treatment for mental health problems but did not get it. Nationally, Black adults are 10% more likely to report serious psychological distress than white adults. Latinx New Yorkers display higher rates of depression than white New Yorkers, but white New Yorkers suffering from depression are more likely to engage in treatment. We cannot wait to fix this problem. The time to address this is right now. At today's hearing, the committee looks forward to hearing from the administration, our community-based organizations, and advocates about how New York City can address this issue head on. And finally, ensure accessible, affordable, comprehensive, and culturally sensitive mental health care to communities of color. I want to thank the administration, DOHMH, Thrive, Health and Hospitals, who are here with us today. I know you are committed to working on this issue for all New Yorkers and to effectively address the mental health needs that arise in our communities. I look forward to hearing from you all today and to learn more about the role that the City Council can play in supporting your efforts. I also want to thank my colleagues as well as the committee staff, Senior Counsel Sarah Liss, Legislative Policy Analyst Christy Dwyer, Finance Analyst Lauren Hunt, and Legislative Intern Stefan Aspromonte for making this hearing possible. I now turn to Public Advocate Jamani Williams, who is with us today to share remarks. Thank you.
Thank you, Chair Lewis. As was mentioned, my name is Jamani Williams. I'm the Public Advocate for the City of New York. I again want to thank Chair Lewis for holding this very important hearing today and for giving me an opportunity to speak. We know that mental health affects us all. And I want to make sure I make that clear. And I want to also lift up Deputy Inspector Dennis Mulaney, who took his life yesterday, showing that this mental health is very real across all lines. And I pray for his family, his friends. Even with that being true, it is right to hold a hearing on the impacts of mental health in the Black and Brown and people of color community. We've seen from infection to injection how much more these communities are affected, and that includes mental health, and that includes sometimes trying to self-medicate to deal with the pain. I have been very open about my own mental health and the services I've received in therapy for at least the past 5 years and the impact that that's had on me and be able to finally have a long, strong, healthy relationship. And I can't imagine trying to go through the times that we're going now without having access to those services. And I'm saddened for those who do not. I am not okay. Those words resonated with a lot of folks last year when I first said them. They understood that what was happening then was just too much. In communities of more color, many people still feel that way. It is too much when a family member or friend passes away from a virus again and again. It is too much when people watch videos of death. These feelings are real, and there needs to be a space for us to talk about how we are feeling when overwhelmed. I have still not looked at the video of George Floyd. I can only take a few minutes at a time on CNN when they speak of what's happening in the courtroom. When I said those 4 words last year, I meant them. The raw emotion exists in communities of more color. At the same time, there can be a stigma when discussing how to manage those emotions. Asking for help too often can be seen as weakness. We need to make sure that there is courage and strength to ask a person for help. People do not need to suffer. When you are not okay, we need to make sure someone is there to help. And as the chair mentioned, even unfortunately, if you have gotten the courage and strength to reach out, you sadly may not have the resources to access the help that's needed. That's why the upcoming budget negotiations are important, and why I keep pointing out we have to send a better message of how we're trying to keep people safe and healthy. While the NYPD's budget will be slightly increasing, the Department of Health and Mental Health Hygiene's budget is going in the wrong direction. Mental health cannot be just seen again as a simple policing issue. It's not a simple issue at all, but we know we can't fix it by decreasing the agencies that are mandated to try to provide the services needed. We do not simply just need more money for NYPD. We need more money for all of these agencies. We need actual investment for communities of more color that is designed to address, not perpetrate trauma. Frankly, communities of more color have struggled with mental health at disproportionate rates. For example, nationally, Black individuals are 20% more likely than others to experience serious mental health problems, according to the Department of Health and Human Services Office of Minority Health. The pandemic has only amplified mental health issues. A New York State Health Foundation report found that 42% of Latinx and 39% of Black New Yorkers reported anxiety or depressive symptoms in October 2020. Clearly, it is difficult for people of more color to deal with the constant threat of virus, lack of stable job opportunities, rising costs, and so many other concerns. We should also be mindful of the number of mental health facilities, as the chair mentioned, in proximity to communities of more color. There are hundreds of mental health facilities across the city, with the most found in Manhattan. Notably, there are some neighborhoods in the city, such as in Southeast Queens or Northwest Bronx, without a nearby mental health facility at all. That highlights the challenge of accessibility to mental health facilities for so many in New York City. This is the right opportunity to propose solutions. Early last month, my office released a report titled "A Renewed Deal for New York City" that highlights some solutions that the administration should explore. The upcoming budget should ensure $7 million for 2 new respite centers and $20 million for 4 new support and connection centers. The latest federal stimulus should help fund this small ask. Finally, we cannot forget about the young people who are all struggling during the pandemic. The budget needs to account for more counselors and mental health staff in schools, not simply, again, additional funding for NYPD. Universal mental health screening is also needed, especially for students affected by the pandemic. We need to lift up our youth who have been historically marginalized, and the budget must reflect that. I appreciate today's hearing, as mental health can still act as a stigma for far too many in communities of more color, communities who need the assistance the most. Genuine investment is needed to make sure we can reduce the stigma and offer help to people of more color who need it. I thank the chair for allowing me to speak. I look forward to today's testimony. And as we redefine what public safety is and what public health is, I hope our dollars show it where our priorities are. Thank you.
Thank you so much, Public Advocate Williams, for joining us today and for your remarks. I also want to share that we've been joined by Councilmember Ayala and Councilmember Ampry Samuels. I will now turn to Committee Counsel Sarah List to go over some procedural matters for this hearing. Thank you.
Thank you very much, Chair Lewis, and good morning, everyone. I am Sarah List, Counsel to the Committee on Mental Health, Disabilities, and Addiction for the New York City Council. I'll be moderating today's hearing. Before we begin, I wanted to go over a couple of procedural matters. I will be calling on panelists to testify. I want to remind everyone that you will be on mute until I call on you to testify. You will then be unmuted by the host. Please listen for your name to be called. For everyone testifying today, please note that there may be a few seconds of delay before you are unmuted, and we thank you in advance for your patience. At today's hearing, the first panel will be the administration, followed by council member questions, and then the public will testify. During the hearing, if council members would like to ask a question, please use the Zoom raise hand function, and I will call on you in order. I will now call on members of the administration to testify, and that will include both members who are testifying and those who will be answering questions. Dr. Mila Harrison, Acting Executive Deputy Commissioner, Division of Mental Hygiene, Department of Health and Mental Hygiene. Susan Herman, Director, Office of Thrive NYC. Dr. Charles Barron, Deputy Chief Medical Officer, Office of Behavioral Health for New York City Health and Hospitals. I will first read the oath, and after, I will call on each panelist individually to respond. Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee, and to respond honestly to council member questions? Deputy Commissioner Dr. Harrison.
Yes, I do.
Thank you. Director Herman.
I do.
Thank you. Dr. Barron.
Yes, I do.
Thank you. Dr. Harrison, you can begin when you're ready.
Thank you so much. Good morning, Chair Lewis and members of the committee. I'm Dr. Mila Harrison, Acting Executive Deputy Commissioner of the Division of Mental Hygiene at the New York City Department of Health and Mental Hygiene, Health Department. I am joined today by Susan Herman, Director of the Mayor's Office of Thrive NYC, and Dr. Charles Barron, Deputy Chief Medical Officer, Office of Behavioral Health at New York City Health and Hospitals. On behalf of Health Commissioner Dr. Dave Choksi, thank you for the opportunity to testify today about the city's efforts to respond to the mental health needs of New York City's communities of color. The Health Department is committed to supporting the mental health and well-being of all New Yorkers, and particularly New Yorkers that are experiencing disproportionate health, mental health, and social burdens. This includes people of color who, in many cases, experience physical health and mental health inequities. Differences in mental health outcomes among racial and ethnic groups are rooted in structural racism and other social determinants of mental health, not biological or individual traits. Social determinants of mental health, the conditions of the environment where people live, learn, work, and play, such as housing, education, income, and wealth, among others, correlate greatly to individuals' and communities' mental health and well-being. For example, our 2017 Social Determinants of Health survey found that serious psychological stress is higher among New Yorkers who experience financial struggles, who feel unsafe in their neighborhood, or who experience challenges with their home and living environment. These survey findings help illuminate how structural racism and our country's history of discriminatory policies profoundly influence the resources, opportunities, and experiences of people and communities of color in New York City. Our 2017 survey also found serious psychological distress was 3 times higher among adult New Yorkers who reported experiencing racism or discrimination a lot or some of the time, compared to people who experienced racism a little or not at all. These findings underscore the importance of applying an equity approach to our work and directing resources to communities experiencing mental health disparities and inequities. I'd like to touch for a moment on how the COVID-19 pandemic is affecting the mental health and well-being of New Yorkers, an area where, again, people of color are experiencing disproportionate health and social burdens. People of color, particularly Black and Latino New Yorkers, have experienced a higher burden of cases, hospitalizations, and deaths from the COVID-19 pandemic compared to white New Yorkers. April and May 2020 New York City health opinion polls also indicate that factors that place adults at risk for adverse health adverse mental health vary across race and ethnicity. These surveys indicate Latino and Asian adults are more likely than white adults to report of job loss or reduced hours, and Latino adults are more likely than white adults to report feelings of financial distress as a result of the pandemic. The health department addresses mental health needs and social determinants of mental health by collecting and monitoring mental health data, working with contracted providers to direct and deliver their services to individuals and communities with the greatest need and that experience mental health inequities, and by investing in services that close gaps in care or address mental health disparities. I will now share some highlights of our work that connects people of color to behavioral health services and increases their access to preventive care. To meet New Yorkers where they live and choose to receive services, we manage mobile treatment programs that provide mental health and substance use treatment and support people with serious mental health concerns, complex life situations, transient living situations, and/or involvement with the criminal legal system. We also control access to 75 mobile treatment teams serving New York City for more than 4,600 treatment slots through a single point of access. Single point of access, SPOA, receives referrals, determines eligibility, and assigns individuals with serious mental illness to the appropriate provider. Mobile crisis teams are an effective and important tool to keeping New Yorkers connected to care over time. We operate health engagement and assessment teams, HEAT, which support individuals in the community presenting with a behavioral health challenge or health concern impacting their daily functioning. HEAT aims to help individuals remain connected to communities, connect them to care and services at critical moments in time. HEAT focuses on reducing racial inequities and receiving referrals from the community and local police precincts to encourage a health response and prevent criminal legal involvement, as Black New Yorkers disproportionately bear the burden of criminal legal system involvement in New York City. The health department addresses social determinants of mental health through one of our largest programs, supportive housing. We contract to provide more than 9,000 units of permanent supportive housing for people with serious mental illness, substance use disorders, and young adults. Supportive housing helps engage New Yorkers with services specific to their health and mental health care needs and provides stable housing for people who have been homeless. The health department also supports communities by helping individuals build resilience. As part of our COVID-19 response, the health department redirected our existing mental health first aid efforts to launch COVID-19 Community Conversations Program, 3C, which provides community training and discussions in English, Spanish, and Mandarin about the mental health impact of the pandemic, structural racism, coping and resiliency skills, and informs residents of available mental health resources. To date, more than 15,000 New Yorkers from the 33 priority neighborhoods identified by the Mayor's Task Force on Racial Inclusion and Equity have taken this workshop. Our Brooklyn Rapid Assessment and Response provides trauma support to communities in Brownsville and Bedford-Stuyvesant, neighborhoods that are disproportionately affected by health inequities. The individuals living in those neighborhoods may have increased risk of mental health challenges and of premature mortality. This program seeks to increase the neighborhood's capacity to plan, prepare, and respond to traumatic incidents to mitigate the negative effects of trauma on individuals and community and increase community resilience. Brooklyn Rapid Assessment and Response provides virtual psychoeducation sessions, healing circles, and ongoing mental health training and support to local community-based organizations, providers, and advocates. Lastly, the health department's neighborhood health action centers in Brownsville, East Harlem, and Tremont provide a variety of resources and programs to serve residents' health needs. Action centers are located in neighborhoods burdened with the health inequities driven by decades of, I should say, centuries of disinvestment. The action centers bring together healthcare providers, government resources, and community-based organizations and programs under one roof. Community members can go to an action center for primary care and mental health care or referrals to healthcare services in their area. These are just a few highlights of our many initiatives and strategies to address gaps in care and social determinants of mental health to improve mental health and well-being across New York City, particularly in communities of color and communities experiencing mental health inequities. In addition to this work, the Health Department provides all messaging and guidance in the languages spoken by the communities we serve. The Health Department keeps a standard of translating all materials into 13 languages, and our COVID-19 related messaging has been translated in up to 26 languages. We rely on the feedback of our partners in the City Council and members of the community like those here to testify today. I want to thank you for your continued partnership, feedback, and support as we continue to care for the health of New Yorkers during this critical time in the city's history. I am happy to take your questions.
Thank you very much. We now turn back to Chair Lewis to start off with questions.
Thank you so much. So as you all are aware, accessible and equitable mental health care and services in communities of color have been historically problematic and even deplorable. So I wanted to provide some context for all of those that are joining us today and do a deep dive regarding mental health deserts. So my first question to the administration would be, what are the mental health deserts in New York City? Share what neighborhoods have the least access to mental health resources.
Thank you so much for that question. I'm going to start it off, and I may turn this over to my colleague from Thrive as well. As you pointed to already, there are differences in mental health outcomes among racial and ethnic groups. And some of those outcomes are really due to structural racism and other social determinants of health and are not individual traits or biological traits of people. And those social determinants of health, as we've been talking about, are conditions of the environment where people live, learn, work, and play, and include, as I mentioned earlier, housing, education, income, and wealth, and really greatly contribute to some of the disparities that we're faced with at this point. I also want to point out that in part through this pandemic, we have learned to take advantage of virtual care in a way that we were not able to do before. And so it is not just dependent on having care in your community any longer. You can get care from any setting, in part if you've got the technology and resources. Telehealth and telemental health were turned on a dime in spring last year in a way that we never thought were imaginable. And that means that care is available to people even if it is not around the corner from them. And it could be across the city where they are then able to access care. I also want to point out that a lot of the care for people in New York City with serious mental illness is available through mobile treatment services. And so those are mobile treatment teams such as assertive community treatment teams and IMT teams where the service can come to the individual where they live. And it is not dependent on having a bricks and mortar solution for them necessarily in their neighborhood, because the service comes to them. The care is coming to them in a mobile way.
So Dr. Harrison, I thank you for sharing that. I understand what you mean, but for those that don't have access to digital devices, it further exacerbates the disparity. And I think what we're looking for is for access to that information that folks in all communities can receive so that they're aware of mobile treatment sites and other ways to get the treatment. So I do appreciate that information, and maybe we can work on a way to share information about mobile treatment opportunities for our communities, because I think that may be another solution to this issue. But I wanted to know if anybody could share specifically which neighborhoods have the least access of mental health resources, if we could name those neighborhoods as we further this conversation.
So I don't have that list in front of me, but I think I'm going to turn it over to my colleague in Thrive, Susan Herman, who can speak to some of the work that Thrive has been doing in this effort.
Sure. Thank you. Thank you, Marla, and thank you, Chair Lewis. Thank you for having this hearing today. What I can say is we'd be happy to provide maps for you of both the 17 federally designated mental health shortage areas and the 33 communities that were hardest hit by COVID. And they overlap in great part. We, as you and I have talked about at Thrive, we have tried to place any of our services that are not mobile, services that are in a brick and mortar clinic, in a school, in a shelter, within areas that need the resources the most. So over 75% of Thrive resources are within these federally designated mental health shortage areas. And if you look at the 33 communities that the health department has designated, first of all, about half of New Yorkers live in those communities. And let's just talk about some of the work that Thrive does there. 76% of our mental health service corps sites are in these 33 communities. We are currently supporting about 430 plus schools in those communities, but that number is growing all the time as we do more and more work with schools in those communities. And that includes on-site mental health services in high-need schools. It includes the work of the school response clinicians, the mental health specialists, and Pathways to Care, which is a new program, a partnership with health and hospitals to provide expedited referrals to assessment and treatment from schools to H&H child and adolescent clinics. Our support and connection centers are both in and will serve neighborhoods that are within these communities. Our social and emotional supports for parents and teachers, over 80% of those sites are located in these 33 communities. So I could go program by program, but we are intentionally placing our programs within communities that need the resources the most.
So thank you so much, Executive Director Herman. I just have to push back a little bit, only because we've been having this conversation, not you and I, but just in general. We've been in this pandemic for a very long time. The fact that we don't have these 33 neighborhoods for this conversation today is definitely problematic. So we need that information. We need to share it. Go ahead.
The fact that we don't have the names of the neighborhoods, is that what you're saying? The 33 communities?
It's about 33 neighborhoods. The reason why I want to share it is because, yeah.
We can share that, and I believe it's up. I believe it's on the health department's website, what the 33 neighborhoods are.
Right. So we wanted to be shared today at the hearing. Although it's on the website, it's important for us to share this conversation so that the public could hear and understand what's happening, because they may not know it's on the website. We could say it's on the website, but they need to audibly hear this information today, because that's definitely problematic that we don't have that. I want us to answer these questions as succinct as possible so that the information is shared today. So although you say it's on the website, we'll get that information from your team, or maybe my team could look for it since it's on the website. But it's important for us to have this information readily available for the community. So I'll just jump into the next question. I wanted to know how your agencies are continuously evaluating and analyzing access to mental health resources across the city by zip code. I heard Dr. Harrison mention earlier regarding data. So I just wanted to know how you're taking that data, evaluating and analyzing that information.
Please just bear with us a minute while we work to unmute Dr. Harrison.
Thank you. Thank you very much. Sorry about that technology problem. So I think you were asking about specifically zip codes and where do we where and how do we collect that information, I think is, and I got distracted by not being able to unmute, so apologies on that. So yes, there's a number of things that we do at the health department in terms of looking at where services are and where services should be. Some of that is through the kinds of data that we collect from community health surveys, which you referred to in your opening remarks. That's one way we collect information about where people of concern might be. We have to combine across years to get at anything close to communities because of the number of people that you need to be able to say that with confidence. We also have targeted our most recent programs. I was talking about the community conversations around COVID, 3C. Those are targeted in the neighborhoods that have been most impacted by COVID and most impacted by social determinants and longstanding disparities and racism. And as I mentioned, all 33 of the task forces, the mayor's task force on racial inclusion and equity neighborhoods, have been touched by those sessions, and we track for those sessions where the people are coming from and what neighborhoods that they're in. So again, it depends on the program, how much information we have about communities, zip codes, or neighborhoods that people are from.
Where is that information being stored or shared?
So the information on 3C specifically is being used to make sure that programmatically we are tapping into the right neighborhoods. And I don't know that it's publicly available, but I'd be happy to follow up with you specifically about that program, for instance. I've also spoken in another hearing about community, the community summaries that we've done at the health department that do look at community health profiles and look at them community by community where there have been impacts of, actually it's not just mental health, it's health and mental health. It's the whole spectrum of care that we're concerned about.
All right, thank you. So if you can share with us, what is your agency or the city in general doing to increase cultural competency among mental health providers, including those in H&H facilities?
So yeah, thank you for that question. As I mentioned, and it's not the same as cultural competency, but I mentioned linguistic translations, language translations of the materials that we put out. I think what I will do is turn this question, since you asked specifically about health and hospitals, I'm going to turn it over to Dr. Barron to speak about the health and hospitals perspective on this.
So thank you for that question. As you know, health and hospitals have a number of facilities across all the entire state. New York's with our acute care and our intensive care, we represent many communities of color around the state, and we are there to say hospital for everyone, especially those of color and suffering from various social determinants of health. We try to reflect our
Deputy Chief Barron, it's a bit difficult to hear you. I don't know if anybody else is experiencing. Okay. This is our new normal, so maybe you want to adjust the computer or the phone. I'm not sure the device.
Computer, I'm not sure why. Try again. We certify the people in our staff that take care of our patients to the communities. We have programs.
Deputy Deputy Chief Barron, you're coming in very choppy. You might need to relocate your computer.
I'm able to relocate the computer.
Move it around a little bit towards the internet, towards the Wi-Fi.
It's on.
Okay, while we work out these technical issues, why don't we turn back to Dr. Harrison, and then we can move on to the next question if we're ready.
I'm not, thank you. I'm not going to be able to respond for Health and Hospitals, but I'm sure that we'll figure out a way to get their response back to you. And I apologize on their behalf.
Thank you, Dr. Harrison. Thank you. So I was able to get the 33 neighborhoods. So this is the neighborhoods, everyone. Lower East Side and Chinatown, Morningside Heights and Hamilton Heights, Central Harlem, East Harlem, Washington Heights and Inwood, Mont Haven and Melrose, Hunts Point and Longwood, Highbridge and Concourse, Fordham and University Heights, Belmont and East Tremont, Kingsbridge, Parkchester, Williamsbridge, Bedford-Stuyvesant, Bushwick, East New York, Starrett City, Sunset Park, Coney Island, Flatbush, Midwood, Brownsville, East Flatbush, Flatlands, Canarsie, Jackson Heights, Elmhurst, Kew Gardens, Queens Village, Rockland. This is just to name a few. So what criteria are used to determine what constitutes these particular communities as a mental health desert?
I will tell you what I know about how these communities were chosen. These communities were not chosen specifically from a mental health desert perspective. They were chosen because of high rates of COVID illness, in addition to other longstanding social determinants that also then impact morbidity and mortality. And those other social determinants included poverty, unemployment, those sorts of factors. So it was a combination of health factors and social determinants that went into naming those communities for New York City. And there are a lot of them, as you've started to name. 33 is a lot of communities.
It's definitely a lot. And while COVID is a factor in this and part of the criteria is definitely some accessibility to mental health services needed here as well. This is even before the pandemic. So I'll just jump to the next question before we open up for our colleagues. And just want to mention that Councilmember Van Bramer has joined us as well. Quick question: in a national survey of state efforts to ensure parity when it comes to behavioral health insurance benefits, New York received a failing grade. So what are your agencies doing to better ensure true parity for mental health benefits?
Thank you so much for that question. We are very concerned about mental health parity, behavioral health parity, as you mentioned in your opening statements as well. You know, we are strong advocates for individuals having the same access and reimbursement for mental health care as other physical health care. We've got groups that advise us and that include community service boards within the health department and our regional planning consortium that are comprised of providers, individuals with lived experience, and others, and they also advocate with us on these sorts of issues. And this is a larger issue. It, you know, does point to, as you mentioned earlier, state and federal issues as well. And we'd be happy to team up with you or anyone from City Council on these sorts of issues going forward. Happy to have follow-up on that.
Thank you for sharing that. I just wanted to know really quickly, is this advocacy work that your agencies are depending on from the community, or is the city undertaking this on an advocacy level?
I think I have to get back to you exactly on how you're framing that question. I'm not sure I have a clear response to that. I mean, we are advised by the Community Service Board, for instance, and they are advising us as the health department. And then if we take up their advice, then it's the city taking up their advice. So I think it's probably some of both, but I'm happy to talk more about exactly what you mean by that question.
Just spearheaded efforts by the city. I'm trying to see if this is spearheaded by the city of New York or if this is depending on agencies, but organizations, but you could definitely get back to me. Just wanted to share we were joined by Councilmember Rosenthal. I am going to yield back to Committee Counsel Sarah Liss.
Thank you very much, Chair. And I'd just like to remind all the council members that if they have any questions, they could use the Zoom raise hand function at this time. Okay, I'm not seeing any questions at this time. So Chair, we could turn back to you to continue if you'd like.
How surprising. Okay, so my next question for the panel, depending upon the community, a need for mental health treatment can be very stigmatizing, as you all already know. So what is the city doing to reduce stigma across different communities?
Thank you for that question. And, you know, we did hear about this as well from our public advocate. I agree that stigma can be quite concerning as a way to impede people from getting care. And again, one of the things that we've been able to take advantage of in this unfortunate time of a pandemic is pointing to the need for mental health supports and resilience in the context of the trauma of a pandemic. And that is one way to bring messages to communities where there might otherwise be stigma around mental illness. It really does normalize the need for support and for self-care and for resiliency building. And I want to say, you give me the opportunity to remind us that although people are experiencing stress and anxiety and depression in the context of this horrific pandemic, for most people, even though there's trauma and loss and grief, most people will be resilient, and we need to work towards helping folks know that and work towards coping and work towards the things that are within their control to maintain resilience within our societies and communities. And so, again, working at levels of the community is one way for us to do that. Some of our community conversations, 3C is one way to do that. We have Project Hope, which is a federally funded program that comes to us in the city through the state that offers crisis counseling and coping and support for individuals as well. And we're working with 21 community organizations throughout the city to get those services and supports out to people virtually at this point in time.
Thank you, Dr. Harrison. So historically, there has been a real lack of financial support for Asian American and Pacific Islanders, mental health care providers for the Asian community, especially during recent events and uptick in hate crimes. What is the city doing to ensure that the AAPI communities have what they need in the way of a demand on behavioral health services?
Again, thank you for that question as well. We've taken on many initiatives to support the AAPI community, and we've continued to promote the mental health services that are available to New Yorkers, including information about NYC Well, the crisis call, text, and chat line that's available 24 hours a day, 7 days a week for anybody who is either in crisis, emotional, or is looking for information and referral to other services. And those NYC Well is available in Chinese language dialects as well for people, and is also translated into more than 200 languages. I think I'm also going to ask Susan Herman to speak about some of the Thrive related initiatives that they're engaging in as well.
Thank you. I think you know that we have a open solicitation out called Communities Thrive. And in the procurement process, it's very difficult for me to talk about it when it's open and people are in the midst of applying. But what I can say is that we have an RFP out for something called Communities Thrive. It's a demonstration project that will involve anchor organizations from the AAPI community, the Black community, and the Latinx community. They will work with local community-based organizations and primary care providers who they bring into the partnership. And through that, we hope to not only launch culturally responsive public awareness campaigns that are guided by and initiated by these anchor organizations, but also to serve many people through telemental health. Our partner is Health and Hospitals. During the pandemic, they've provided about 200,000 telemental health sessions, in addition to the 1 million, I guess 1 million total telehealth, and 200,000 of those are telemental health sessions that they've provided. So they've become quite expert in doing this. They are our partner in this initiative, and we believe generally, it's not just Communities Thrive, but generally, we believe that if people can get either mental health treatment or mental health support that will change the interaction between a social service provider, say, or a teacher or a guidance counselor and a client or a student, that interaction will go better. And if people can refer them to services when appropriate, that's helpful. So for instance, in our Connection to Care program, which was a 5-year demonstration project, we worked with 14 community-based organizations, some of which serve the AAPI community. They helped 46,000 individuals over that period of time. And what we know, these are social service agencies where people are going for other reasons. They're going for housing, they're going for employment counseling, they're going for legal services, range of social services. While there, if they have a mental health challenge that has been identified by a staff person who's been trained to do that, not only does that interaction go better, but a mental health partner that they're working with is easily accessible, and people can be and were and are referred to treatment. So we believe that there are a number of ways of serving communities of color, and one way of doing it is by working through trusted members of their community, both local community-based organizations, faith leaders, places of employment. We have launched dozens of webinars to train nonprofit employers and corporate employers how to create and promote a more positive work environment that promotes mental health. We have worked and are continuing to work with faith leaders across the city so that as the people many of us turn to for solace and comfort, when they know that someone is facing difficult times, hard times have fallen on them, they are better trained to recognize trauma and to know how to respond appropriately. So we are, in many ways, we're working with the people community members already trust to help get community members to the appropriate care at the right time. That's why we're in shelters, that's why we're in schools, that's why we're in social service agencies, that's why we partner with faith leaders.
Thank you, Executive Director Herman. So if we could just do a quick little deep dive and share some more information about Communities Thrive. I know that both Thrive NYC and Communities Thrive both attempt to bring mental health resources to vulnerable communities, particularly communities of color. So how do both initiatives differ?
Thrive NYC is a citywide commitment to help people who need help get the help they need, and to try and make sure that fewer needs turn into crises. We work with 13 city agencies, and right now we have about 30 programs that are designed to fill gaps in care across the city, definitely with a lens of equity to try and make sure that people who live in historically underserved communities get the help they need. Populations that are typically not well served get the help they need. So that's Thrive. That's the umbrella of all the work that we do. Communities Thrive is a program or an initiative that we will launch within that umbrella. And typically we partner with agencies. We also work with nearly 200 community-based organizations to do our work. Communities Thrive will be one of those programs within the Thrive NYC umbrella.
And how many individuals will Communities Thrive intend to serve?
Well, we're looking forward to reading the proposals to see what our applicants tell us about that.
And what's the criteria for the RFP? How are these organizations being chosen?
For that, I would like to refer you specifically to the RFP rather than have me paraphrase how they'll be chosen. The criteria is posted both on the HRA website and Thrive, and the due date is April 23rd. I encourage organizations to apply if they're interested, and we look forward to a very exciting program.
All right, thank you. I'll yield back to Committee Counsel Sarlis.
Thank you very much, Chair. And I see that Councilmember Rosenthal has a question.
I'm starts now.
Great, thank you so much. And I apologize, I'm in my office, so I'll flip my screen. But anyway, thank you so much for this hearing, Chair Lewis. It's a really important topic. And Director Herman, you know, I'm a huge fan, so thank you for all the effort and smarts you put into this work. The city's lucky to have you.
Thank you.
I'm wondering about two things. One, for the RFP, how much money is going into this? How much money will the city spend?
This is an investment that will be about $3.7 million over a 2-year period. It's a 2-year demonstration project.
Okay, 3.7. So about
3.7, sorry.
Right. So about 2 million, shy of 2 million a year. And that'll start when? Fiscal year 22? Or what month?
Well, we hope that it will actually begin, that the work of it will begin in June. So there'll be a little bit in FY21, but it will go mid-June, say 2021 through mid-June 2023.
Got it. And how many groups are you expecting to choose?
So we will have 3 what we're calling anchor organizations.
I see, that's subcontract. Okay.
Each anchor organization will bring as part of their team 5 CBOs, 5 community-based organizations, and 5 primary care providers.
How much money will each anchor provider get, roughly?
Well, that's part of the proposal, how they will divide up the money.
Okay, so each anchor group each year gets about $1 million.
Well, I'm not
shy
sure
of $1 million
that way. We also have telemental health provider, which is H&H, and they will get some of the funding.
And they will get some of the funding. So each anchor provider might get like 600, 700,000.
They are asked to propose how much they will get and how they will distribute the funding to the primary care providers and the social service agencies.
Right. Director Herman, the reason I'm drilling down on this is simply because we've all seen the magnitude of the need, but we've all seen also, to your point, that it's the culturally competent groups that can really serve our communities. So I'm just trying to wrap my head around about how much money each group would get, and then what are we asking them to do? And through really sloppy mental math, it sounds like we'll give each nonprofit about enough money to pay for one staffer to do this work. Is that a fair?
We're not asking the nonprofits to provide the telemental health. We're asking H&H to provide the telemental health. We're asking the anchor organizations to help with a public education campaign and to work with H&H to provide training to make sure that with all of the bilingual capacity that they have, that they're even better at cultural responsiveness. And we're asking the social service agencies to provide places for people and to encourage appropriate people to access telemental health. We're not asking.
Got it. I'm sorry. I was late to the hearing.
Okay.
Thank you. To provide places. Okay.
And to refer appropriate people and encourage them, clearly. But
I see.
is the provider.
Gotcha. Okay, so the majority of the funding, you would educate the nonprofits basically to educate their staff, right, to refer people to the mental health.
Time expired.
Okay, so I have another set of questions. Chair Lewis, may I have a little bit more time?
Please do.
Okay, thank you. Director Herman, I am wondering what you think about the incident of the hate crime against the I'm going to say middle-aged Asian woman who was kicked and beaten on the street in the last week. As soon as the police identify the man and apprehend him, what's the right response outside of the criminal justice response? What's the right response for how we prevent this from happening again, in your mind's eye?
I think Dr. Harrison is trying to.
Yeah, I'm just wondering, council member, if you'd like me to take this from the
absolutely.
Again,
I'm on my phone, so I can only see one person at a time. So yes, of course. Thank you.
Okay. So let me address your question. I think you're asking a fundamentally important question, and that is, and it's complicated by, this horrific hate crime issue, issues of violence against Asian Americans, Pacific Islanders. It's something that we are all horrified by and need to be very concerned about it. I also want to say that I think we need to say a few things about these sorts of incidents. One is that hate is not a mental illness, and we need to think about the societal city response to these issues outside of thinking about this solely as a mental health concern. But having said that, I also want to make sure that we don't neglect issues around mental health and mental illness. And I want to remind folks here that people with mental illness are more likely to be victims of crimes than perpetrators of crime. So I want us to remember that. And yet, if there is somebody with mental illness, that we make sure we are aiming to connect them to care and services in the best ways that we have and know. And so if there's somebody coming to the attention of the community or communities with signs and symptoms of mental illness, we should know what to do about that and how to respond to that. And knowing that there are resources outside of legal, criminal justice and police response, we should be aware of that as well. So in New York City, we have mobile crisis teams who are available to respond to crises in communities, in homes. They are accessible through NYC Well, 888 NYC Well. Anybody can call. We know that, we've got to respond faster than we have with those sorts of programs. But I know that's something that we're working on. And I think one of the last hearings we were at together, Susan Herman spoke about a pilot program, which is a diversion for 911 for people who have health crisis concerns. So, I think we've got to be thinking about all of those types of responses and connections for people who do have mental health needs when it isn't just a criminal justice safety issue, when it does involve more complex issues.
I mean, maybe I'm making some assumptions about the person who did this. Maybe I'm making some assumptions, but I guess most importantly, what I was hoping I would sort of cull out from what you're saying, all of which is incredibly important, is how could we have gotten to this guy sooner and gotten him the help he needs so that this wouldn't have happened.
And that again is a really good question. And the other resources that I didn't mention a few minutes ago for us to be aware of and to help make connections to is assisted outpatient treatment, which is court mandated treatment for individuals who qualify, which is another way to help people stay connected to care if they qualify for legally mandated outpatient services.
Let me ask another question. In this situation, will there be, if there's mental health issues involved, if the police identify the person, apprehend him, will there be a connection to some sort of mental health service for this gentleman?
So
how could there be? How does the system work? So, yeah.
Yeah, again, thank you. I don't think I can't comment on any one specific situation or individual for various reasons. And I don't think that will help us here. However, can I actually add one more?
Broadly? Yeah. Sorry, more broadly then.
So we've been spending time trying to build up the city's resources for individuals who have histories of falling through the cracks of the system. And we've been doing that through lots of work with Thrive NYC, which is one of their main goals in terms of preventing, again, people from falling through the cracks. So there are numbers of services that we've put in place that we've grown over the years that haven't been there before. For instance, a program such as our support and connection centers, where police can bring individuals who have behavioral health concerns to a setting for an assessment and evaluation outside of an emergency room. And, I also, so in addition to support and connection centers, and I heard Public Advocate Williams mention them in his opening comments as well, we've increased our access to mobile treatment For individuals throughout New York City over these last 5 or 6 years, we've created new programs called intensive mobile treatment, where you don't have to have a diagnosis. You may be homeless, you may have criminal and legal involvement, you may have substance use, and we have 11 of those programs operating now. We had 0 of them 6 years ago. So we've been working towards increasing access to care for people who really do have, our system has failed them before. And I can mention additional forensic, assertive community treatment programs. I mentioned mobile crisis teams available where we are working toward a more rapid response. So there have been a number, I'm sure I'm leaving some of the expansion efforts out, but there've been a number of those throughout.
Yeah, I appreciate that. And more details I think would be important for the council. So if you do have lists of those, I think the council would be interested in seeing it. And I see my colleague has his hand up. I just want to pursue this just for 1 minute and then maybe I'll come back. But like, we had a briefing yesterday by our police, our local police precincts, about some crimes that have been happening in the district. And all of them fundamentally the perpetrators need social services, right? So the police like to say, oh, they're just revolving. We call them the revolving. We know these 2 guys. They've been in and out of the system 24 times. Gosh, is anyone else interfacing with those people who have been in and out of the system 24 times besides the NYPD? Is there a system set up that you have through any of these programs with the PD where they're encouraged to refer these types of cases out? Both my precincts say it with the intended goal of getting more police officers, right? So what they're saying to me is, we've got these roving criminals who go in and out of the justice system. We arrest them, they go out. An hour later, we arrested the same guy. And their answer, they say to me, so we need more police. What is that the administration's thinking, and are precincts being given other options, or is that as far as it goes? Because we do have CVAPs, we have a couple of, I guess, social service people in the NYPD. Do you understand where I'm going with that?
So I'll start off, and it looks like Susan might want to respond as well, to say that we have resources that we've added over the years from the mental health perspective, and I'm going to name 2. One are our co-response teams. These are police officers teamed up with mental health clinicians who are available to go out for individuals that, may be similar to what you've described, where there's concerns about repeated involvement with legal issues that, really might be behavioral health focused.
And is that in every district, or just the ones that have the highest crime levels? Because I don't think my district has those.
So let me just, so there's co-response teams, and then there are also HEAT teams, health engagement and assessment teams, which are clinicians paired up with peers, people with lived mental health experience or justice experience, who are available to go out to folks, again, in the community. These are accessible through a triage desk, and police are able to make referrals to the triage desk for individuals that they are concerned about. And
able is very different from do. right?
Sure, and I hear you on that.
Educated.
So,
Yeah.
so
well,
you know,
whatever.
again, people have to know and use it, but those are services available, and we've increased our heat teams recently, and there are going to be more of them available. I don't know, Susan, would you like to add anything to what I've said? From
I think you covered it. I would just say the police officers in your district, Councilmember Rosenthal, should be aware of the fact that co-response teams operate citywide and that heat teams operate citywide. And there is now a behavioral health unit in the police department. They can call the unit, they can talk to the unit about particular issues that they have. They can call in and talk about a particular person to the triage desk, and the triage desk can decide whether it makes sense to send a heat team or to send a co-response team. But the complaint about the criminal justice system being a revolving door is, as I think you are indicating, it's a critique of the criminal justice system as much as it's a critique of everything else. And to the extent that we can make the criminal justice system more effective in its rehabilitation mission as well as its punitive mission,
Yeah, thank you.
We may be better off.
Look, I'm gonna stop, but I do think it's interesting that on this call, I didn't hear about either of those things. I mean, this was a call with the heads of 2 precincts and the electeds, and saying, you know, what can we do to help here? And the answer was, from one precinct, nothing, you know, give us more cops. And the other precinct did a little better. They said, we have now youth officers in the NYPD, and those youth officers are visiting the homes of the knuckleheads once a week. But similarly, they sort of, you know, toss up their hands and said, you know, no one's home. So of course these kids are on the street doing this. Again, at least they're going to the home, but I don't see any connection to social services. But perhaps we've gotten off track, and I want to defer to my colleagues. You know, a lot of times in government, I think we think the system's working, and maybe it is for a couple of precincts, and it's not for a couple of others. So maybe we can follow up. Thank you for your time.
Thank you very much, Councilmember Rosenthal. And we'll next turn to Councilmember Riley. Just a reminder again to council members, if you have questions, please use the Zoom raise hand function. And we'll go to the public panel after that. Thank you very much. So Councilmember Riley, you can go as soon as the sergeant cues you.
Time starts now.
Thank you, Council, and thank you, Chair Lewis, for this opportunity. I won't take too long. Thank you for the testimony this morning, Dr. Harrison and Director Herman. I just wanted to see if we could just further explain the resources out there for students who have been going through such a, traumatic transition during this pandemic. We do have many high school students who are even able to play in their athletic sports. Some that weren't able to go to prom, some that won't even be able to graduate and do simple things that we all may have done when we were in high school or our collegiate years. So just want to emphasize and speak about those resources that we have for those students, and also for the parents who have younger students like myself, who have students that, aren't able to socialize with their peers. So if there are any programs and resources out there, I just want to emphasize, I'm sorry if you spoke about this earlier, but just wanted to speak about them now if possible. And I do appreciate all the work you have done.
Great, thank you so much for that question. I think that you're spot on to ask about the needs of kids. Again, we are living through something we have not lived through before that clearly is going to impact all of us and all, everybody in our families, kids, adults, throughout the communities. And you know, thinking through the needs of kids and families has been critically important to us. From the pandemic perspective, there is information on the health department's website in terms of managing stress and coping, both from the perspective of adults as well as parents and for kids. And I can help point you to those materials if you haven't seen them. They have been translated into many, many languages. And I understand that I cannot speak for the programs that Department of Education is working on now, but I understand that there are some resources through the DOE as well. I don't know, Susan, do you want to add anything from
Are there any, I'm sorry to cut you off, Doctor. Are there any programs with our CUNY schools for our kids that are in college?
Susan, do you want to
I'd like to, if I can jump in, I can talk a little bit first about what our students that are in our throughout the public school system have available to them. In addition to the resources that are on the health department's website, there are also particular resources geared for students and young people on the Thrive website, services that can be accessed while staying at home. In addition to that, every school in the city has access to mental health care in one form or another. So there's either an on-site clinic, there's access to a clinic working in partnership with a community-based organization. We have school response clinicians who respond to schools if students are experiencing particular distress, and they can counsel them. They might counsel a whole classroom if something upsetting happened to a classroom, and they can stay with that student if needed until that student is connected to care. So there's on-site services as we open up. There's people who come to the school response clinicians in times of particular trauma or stress. And there's also school mental health specialists who work with schools to both increase the capacity of school staff and teachers to work with students effectively and appreciate their mental health needs. And they also will be, if they haven't already, started running groups for students who are particularly troubled and would like to have a little bit more attention, and they'll run groups for them. So we have a lot of resources. We also have created something called Pathways to Care, which is a partnership between DOE and health and hospitals, where we're starting in the 33 communities that have been hardest hit by COVID. We're currently working in about 44 schools, but soon hundreds more will be added. We're going by each child and adolescent clinic that H&H runs and associating them with schools that have on-site resources.
Thank you. Thank you, Director.
Jumping in.
Thank you, Director, and thank you, Dr. Harrison. Thank you, Chair, for this opportunity, and I would like to yield my time. Thank you.
Thank you very much, Councilmember Riley. And again, just one other reminder to the public that you will be testifying next after this. And right now, if any other council members have any questions, please use the Zoom raise hand function. And Chair Lewis, we can turn back to you for some further questions.
All right, thank you. I'll be quick as I see hands up from the public. Earlier, I was trying to ask Dr. Barron a question and wanted to know if everything is working now. So I could quickly ask that question. Is he still on? Perfect. I wanted to know, what is the city doing to increase cultural competency among health providers, particularly those in H&H facilities?
Oh. We can't hear you.
He's not on mute though.
Dr. Barron, we're still having difficulty hearing you. So we're going to turn back to the chair for any other questions she may have for either Director Herman or Dr. Harrison.
Sure. And I want to thank Councilmember Rosenthal for kind of opening this Pandora's box a little bit. So I just have a quick question. As I was listening to Executive Director Herman and Dr. Harrison speak, I was thinking about the referral process when folks are in contact with agencies. So my question is, how are individuals who are deemed mentally ill by other agencies, for example, if a homeless person that is deemed mentally ill by DSS wants to access the DOH-MH system, how does that process work? How do you all coordinate?
That's a fantastic question. Thank you for asking it. So when there's somebody within any other system and they would like to have access to one of the mobile treatment services, for instance, which is one of the ones that we have the single point of access for, they make a referral to the Department of Health and Mental Hygiene and share the information that we need to know so that we can then assign that person to a treatment provider. And we have spent the last about year and a few months working on improving coordination across various services and systems such as Department of Homeless Services, correctional health services for people coming from Rikers Island, health and hospitals. We have been sharing information across our various service systems so that we can help keep the connections and the flow going, so that we can see for somebody who's making a referral that the information is complete and accurate and getting to us in a timely way, that we are making the referrals in a timely way, and that folks are connecting to care. And we are measuring and monitoring how well that we've been doing that as well across these various agencies.
Thank you for that. And I wanted to go back to the community anchor conversation we were all having earlier. I wanted to ask, how are we requesting or asking the anchor organizations to assist with the public education campaign? Like, what metrics are being used to ensure that they can effectively provide the information to the community?
They will be essentially asked to design these public awareness campaigns, work with the community to do that. And
what metrics are being used to measure if it's effective or not? I know that they have to put this information
They do. So I can't talk about that. They will propose how they will measure effectiveness, and they will propose how they will create sustainability plans as well.
Okay, so will this information, I guess after the RFP is closed, will this information and data from the program be publicly available?
There will be metrics about reach and about impact posted about Communities Thrive, as there are metrics about reach and impact about every single Thrive program posted on our website. Every single one is on our dashboard with data about how many people they've served and what the impact of the work has been.
And last question on the anchor program. So one of the goals of Communities Thrive is to provide telehealth and mental health services to underserved communities. So will the program include funding to support technical upgrades and purchases for New Yorkers without internet access? I know you mentioned earlier, Executive Director Herman, that H&H will play a role in this, but how will that look?
Well, the equipment for the mental health sessions will be provided as part of this program within the CBOs and the primary care providers. But something that H&H has done that I think hasn't gotten a lot of attention is that they have also provided cell phones and service for people to help keep them connected to telemental health. During the pandemic, they've done that for hundreds and hundreds of people. And if that's necessary in this program, they will likely do that as well.
All right, thank you. I'll yield back to Committee Counsel Sarlis.
Thank you very much, Chair. And I'm going to just pause here to see if there are any second round of questions for any council members before we turn to the public. I know the public is very eager to go right now. Okay, so we can turn back to you, Chair Lewis, for any closing remarks that you may have before we can, and then turn to any members of the administration if they have any closing remarks.
I just wanted to thank the administration and service providers for testifying today at this oversight hearing in relation to access to mental health care in communities of color. While mental health is not a sexy topic, it is even more relevant today as millions of New Yorkers are still struggling to recover from the devastating toll of the COVID-19 pandemic. Today, we recognize the depth of work that we need to urgently but thoughtfully undertake to remove the barriers to mental health care in communities of color in this city who have experienced generations of racial disparities in our hospitals and neighborhood clinics. I definitely want to thank committee staff Senior Counsel Sarah List, Legislative Policy Analyst Christy Dwyer, and Financial Analyst Lauren Hunt, and Legislative Intern Stephen Aspromonte for helping and making this hearing possible today. I look forward to working with all of you to continue to address this matter, and I will yield back to Sarah List.
Thank you very much, Chair. And that concludes this panel of the administration. We thank you all for coming here today. And we'll now move on to public testimony. So just a couple of procedural items. All public testimony will be limited to 3 minutes. After I call your name, please wait a brief moment for the Sergeant at Arms to announce that you may begin before starting your testimony. And again, as before, there may be a few seconds of delay before you're unmuted. So we thank you in advance for your patience. And the first panel that we will be going to hear from the public is going to be Zainab Tawil, Ju Han, Joy Luong Faze, and Yuna Yoon. So Zainab, as soon as the sergeant cues you, you can begin your testimony. Thank you.
Time starts now.
Oh, let's just pause the clock. We'll just work to unmute Zainab.
Apologies about that. Can everyone hear me? Okay. Chairperson Ayala, members of the Committee on Mental Health and Disabilities and Addiction, I want to thank you for the opportunity to testify before you here today. My name is Zainab Tawil, and I'm a mental health caseworker with the Arab American Association of New York. To say that there's a profound mental health crisis in New York's Arab American community would be an understatement. Of particular worry during the COVID-19 pandemic is the rise in domestic violence in our community due to the exacerbated conditions created by the pandemic. It's an unfortunate truth that in some Arab households, women find themselves victimized at the hands of abusive partners who wield absolute power over their lives. Organizations like mine provide women at risk of falling into these situations with resources and information that could protect them from abuse, and we have fought to keep doing so during the pandemic. However, at-home quarantines, loss of access to culturally acceptable spaces outside the home, and increasing household tensions surrounding at-home schooling and loss of income have put thousands of Arab women in situations where their lives are literally on the line. As this pandemic shuts down and cuts off our community for mental health resources, we anticipate these negative impacts will increase and intensify the longer the pandemic carries on. The stigma surrounding mental health care in the Arab community destroys lives every day, and having the resources to meet our community where they are and provide life-saving care is essential. The Arab community is not alone in this struggle. We are just one of countless communities of color without ready access to mental health care in New York. Whether they just arrived in this country or if they've spent entire lives here, every New Yorker deserves and needs mental health support, and we need City Council to step up and provide this support as much as it can. Especially with the rise in hate crimes, it is imperative that the city support initiatives coming from the voices of our most vulnerable community members, including the Asian American community, which has faced countless hate crimes in the past year alone. Initiatives like Hope Against Change, created by the Asian American Federation, aimed at obtaining funding for Asian American organizations who are doing on the groundwork fighting against anti-Asian hate by building resiliency within our communities. This initiative is critical to ensure the mental health needs of survivors of anti-Asian violence are met. City Council could play a critical role in supporting survivors of violence across the board and guaranteeing that this work continues to stop violence by continuing to fund organizations like ours. Thank you so much for your time today. I appreciate your attention.
Thank you very much. We'll next turn to Juhan, and you can begin as soon as the sergeant cues you.
Time starts now.
Thank you. Thank you, Chair Lewis and all committee members for holding this important hearing today. I'm Juhan. I'm the Deputy Director of the Asian American Federation. Since the beginning of COVID, the Asian American community has withstood an unending trauma, from experiencing the highest increase in unemployment rates across all racial groups, to our seniors suffering severe depression, to the surge in anti-Asian violence that has compounded the mental health burden of the poorest community in New York City. For a community that already struggles with deep stigma, which is the biggest deterrent to accessing services, as well as multiple systemic barriers, Asians are the least likely of racial groups to utilize mental health services. When you consider the racial trauma of being attacked on a daily basis, Asian New Yorkers are facing a public health crisis within a public health crisis. In this unimaginable year, mental health has become inextricable from public health. In the case of the Asian community, it's become synonymous with public safety. We must reimagine what mental health means in this moment for a community that has not only lost jobs at the highest rate in New York City, but also regularly faced shootings, stabbings, and other forms of violence. Mental health during COVID means all the ways that our physical safety is addressed so that our mental health is protected from further trauma. As an organization that has led the response to the surge in anti-Asian violence since January 2020, but the Asian American Federation urges City Council to integrate and support all programming that aims to reduce the mental health impact of Asian hate crimes across all agencies. We cannot leave public safety strictly in the hands of the NYPD, which is limited in its ability to provide meaningful safety for our community. The Federation has tracked over 1,100 bias incidents across our reporting tool, as well as Stop API Hate, NYPD, and Commission on Human Rights, which equates to more than one incident every 8 hours from March of 2020 to February 2021. This number actually only accounts for about 10 to 30% of the actual number of incidents due to the drastic underreporting in our community. Yet the majority of surveyed Asian Americans have also said that their mental health has been impacted by the rise in violence. So to provide immediate safety solutions to Asian New Yorkers, the Asian American Federation recently launched our Hope Against Hate campaign. The campaign also seeks to support the work of our mental health panels here on this, partners who are on this panel, and working tirelessly to support the uptick in demand for culturally competent mental health services. Across federal, state, and city, we're asking for a $30 million investment to stem the tide of anti-Asian violence with community-centered strategies that have proven to work. Because we're in the thick of city budget discussions, we're asking for City Council to step up with new initiative funding for this work, because we will need widespread support to reduce these daily attacks on Asian New Yorkers. Our campaign will centralize the reporting of bias incidents through an in-language reporting tool in order to connect victims to the support that they need, establish safety programs in Asian majority neighborhoods in Manhattan, Brooklyn, and Queens, outreach to local small businesses and faith centers to establish safe zones where individuals can go to seek help and support if they're ever being targeted, provide upstander verbal de-escalation and physical self-defense trainings in multiple Asian languages, and set up in-language victim support services, including assistance fund to help with assault-related expenses and mental health support in the languages and the cultures that they need. On behalf of the Asian American Federation, I thank you for your support, and we look forward to working with all of you to address this crisis and the mental health toll it's taking on the Asian American community.
Thank you so much. And we'll next turn to Joy Luang Faze. You can begin as soon as the sergeant cues you.
Time starts now.
Good morning. My name is Joy Long Pasai, Assistant Executive Director of Behavioral Health Services at Hamilton Madison House, or HMH. First, I would like to thank the City Council member, Chair Lewis, for this important hearing. HMH is a multifaceted community service organization operating in Chinatown on the Lower East Side and beyond. Our program focuses on early childhood education, serving seniors, and the subject upon what we're focusing on, behavioral health. We specialize in providing behavioral health services to people of Asian descent. In fact, are the largest outpatient behavioral health provider for this population on the East Coast. Currently, we operate 5 mental health clinics, a day treatment program, and a supportive housing program for adults coping with severe mental health issues. Our staff are at least bilingual, and languages spoken among them are Chinese, Japanese, Korean, Cambodian, and Vietnamese. The large majority of the people that we serve are first-generation immigrants of low-income status, and many are receiving therapy for the first time. Consistently, they share that their mental health symptoms relating to difficulties with employment, finances, housing, immigration status, and health. Compounding the situation is the stigma associated with therapy in the Asian American community, the effects of the COVID, and the anxiety provoked by the recent shares of racial incidents targeting Asian Americans. The recent report released by the Stop AAPI 8 relieved nearly 3,800 incidents were reported over the course of roughly over a year, and we believe that that's a tiny fraction of the total. HMH has seen an increase of individuals seeking support and mental health services by 10% in the last 3 months and 25% since the pandemic. The fears of being attacked, increased anxiety, and depression are common issues reported. For all these reasons, we believe it is imperative that the City Council makes it a priority to fund initiatives and work with community organizations and mental health providers to tackle anti-Asian violence and further expand mental health services. Following are the recommendations. An anti-Asian against violence campaign such as Hope Against Hate should be undertaken and funded to encourage Asian Americans to make use of mental health services, as well as to engage them in other social health and educational programs that could prevent mental health from arising. As earlier discussed, this is a shortage of mental health clinicians. It is even more so in the Asian community. We should pursue strategies to attract more Asian Americans into the mental health field to incentivize employing them at community-based organizations where we have already earned the trust of the community. Additionally, funding should be available to organizations that are already providing the critical support to ensure mental health needs of survivors of anti-Asian violence in Asian neighborhoods are met. Hamilton Madison's House would like to thank the Committee of Immigration and the Committee on Mental Health, Disabilities, and Addictions, and we would be gladly to engage in ongoing discussion to foster better mental health among Asian Americans and all New Yorkers.
Thank you so much. And we'll next turn to Yuna Yoon, and you can begin when the sergeant cues you.
Time starts now.
Thank you, Council and Chair Lewis, for this opportunity. And as Chair Lewis emphasized, we need more support for POC as a whole. Thank you for those who professionally and as individuals show solidarity and allyship during such a difficult time for Asian Americans. Calls coming into KCS, the only state licensed clinic targeting the Korean community, taking majority Medicaid and Medicare, jumped dramatically, and our wait list has grown. It shouldn't come as a surprise. People who appear on the news for anti-Asian hate crimes are reaching out to community-based mental health clinics such as KCS because we have trust in the community to do the difficult work of processing their and their families' pain. When the same issue is impacting multiple systems, from medical to law enforcement and security officers to the criminal legal system, clients finally come to us carrying all of that with them. They take a leap of faith that they can heal and bravely work towards feeling safe to leave the house again and carry on with their lives, even while still dealing with pending cases and the uncertainties and disappointments. In directing a clinic, I'm speaking as a social worker with a dual responsibility of maintaining patient confidentiality, but also upholding our code of ethics, where within and outside of our professional roles, we have a commitment to advocate for social justice. When people can't open up to others when investigations are pending, when they express concerns about systems not meeting or providing sufficient resources for their needs, the impact that mental health professionals have when they hold space for their trauma is absolutely priceless. And yet there's limited research with sufficient disaggregated data that can provide more intensive and tailored approaches and can help us make cases for the kind of funding that we may qualify for and deserve. As the demand for support rises due to the sheer number of attacks and the direct physical impact and sense of safety that the community has among their fellow New Yorkers, this is a shared responsibility. My staff also must have all the support they need to provide this essential work without vicarious trauma and burnout. Even for myself, as I go about my day and have conversations with various incoming clients and my staff, it's just not okay. We can do better. And with your support, we can make a start. Thank you.
Thank you so much to this entire panel. And I'm going to pause briefly now to see if there are any council member questions. Okay. Thanks again to this panel, and we'll next turn to our following panel, which will include Erica McSwain, Nadia Chait, Fiona O'Grady, and Kimberly Blair. And we'll begin with Erica McSwain, and you can begin as soon as you're unmuted and the sergeant cues you.
Time starts now.
Good morning, Council Chair Lewis and esteemed council members. My name is Erica McSwain. I'm the director at the Queens Community Justice Center, which is a demonstration project for the Center for Court Innovation. Young people involved in the justice system have often experienced a history of significant trauma. The burden of processing and acknowledging the trauma should not fall on young people who are in no position to do it alone. Our young people of color report a lack of comfortability in traditional therapeutic settings operated by individuals unfamiliar with their unique needs. With the populations we serve facing ongoing police violence and a public health crisis that disproportionately impacts Black and Brown communities, realizing the vision and equitable access to mental health services is now more important than ever. Young men of color are underserved, oppressed, and victimized by current systems, and the Center for Court Innovation offers trauma responses across the city that adequately and appropriately address the victimization. At the Center for Court Innovation's Neighbor in Action site, we provide comprehensive trauma-informed services to young men of color between the ages of 16 and 24. To address these impacts of various pressures, we provide therapeutic services, which include psychotherapy, psychoeducation with culturally responsive delivery, intensive case management, and mentorship to support them in recognizing their trauma and engage in healing. In Queens, the Queens Community Justice Center provides comprehensive services to young people harmed by violence by similarly taking a trauma-informed, culturally competent, holistic approach to work with each participant. Uplift is a trauma-informed, culturally competent victim service program for young people in Queens who have experienced victimization and/or exposure to violence by providing client-driven individual therapeutic sessions and supportive workshops. Queens Community Justice Center is ready to implement Uplift with support from council and transition services from mandated involvement to voluntary, meaningful engagement for young people of color in Queens. The center's Harlem Community Justice Center builds on this evidence-based approach to mental health through the Men's Empowerment Program, which provides trauma-informed programming and mental health interventions to young and Black Brown men who have experienced trauma of mass incarceration and/or community violence in East and Central Harlem. In 2020, with council support, the center's Staten Island Justice Center began providing more robust programming, mental health services to youth who are justice involved or have experienced a history of trauma through the Youth Wellness Initiative. They also plan to expand these programming to include workshops designed to address trauma and produce healing. The Center for Court Innovation is committed to working with council to ensure the needs of marginalized New Yorkers are addressed through access to mental health services and support. We thank the council for its continued partnership and will be available to answer any questions you may have. Thank you.
Thank you so much. And we'll next turn to Nadia Chait, and you can begin as soon as the sergeant cues you.
The time starts now.
Thank you, Chair Lewis and members of the council for holding this hearing on such a critical topic. I'm Nadia Chait, the Director of Policy and Advocacy at the Coalition for Behavioral Health. Our members are community-based mental health and substance use providers who are truly embedded in New York's communities and working in the communities they serve every day to meet their needs. It's for this reason that the majority of individuals that our members serve are people of color, and that the majority of people who are employed by our members are people of color. And so we're working every day to address many of the issues that have been raised today. And yet, as you rightly noted, Chair Lewis, this is a long-standing issue, one that started before COVID, certainly been worsened by the pandemic, and one that needs solutions that we as providers have not been able to accomplish on our own. We need assistance from government to truly be able to meet the needs in our communities. It's clear to us that one of the biggest challenges in providing care is that our workforce is simply insufficient. Due to low Medicaid rates and insufficient city contract funding, our staff simply are not paid the wages that they deserve. And in addition, many of the structural barriers that lead to, that were discussed earlier, that lead to individuals of color often having higher mental health needs, similarly impact the ability of individuals of color to enter our field, which often requires master's degrees and significant levels of student debt that unfortunately are not, really mitigated at all by city or state programs. And so to increase our workforce and really increase the capacity of our system to get rid of the wait lists and the appointment delays that folks reaching out for help encounter far too often, we would really encourage the city to look at creating more sustainable funding streams for our providers. So that would include fully funding the indirect cost rate initiative so that providers' costs are actually covered, increasing funding on city contracts to provide higher salaries for staff and to support our staff, and then really investing in the city council's mental health initiatives. I think that funding does a remarkable job at targeting services to communities where the need is very high. And obviously you all as council members know your communities, know where that need is. But the cuts last year did have a really detrimental impact. 40% of the funded providers that we surveyed reported serving fewer people. So bringing that funding back at minimum to the FY20 baseline, but we would really encourage increases in that funding for FY22. And then really funding programs in the community, not expecting folks, to go outside of their community or to go to hospitals, funding programs where they are, in senior centers, in schools, in homeless shelters. Thank you for your time.
Thank you very much. And we'll next turn to Fiona O'Grady. And as soon as the host unmutes you and the sergeant cues you, you can begin.
Time starts now.
Oh, you're still on mute. Let's just wait for the host to unmute you. You may have to accept an unmute prompt.
That's better. Good morning. My name is Fiona O'Grady, and on behalf of Samaritan Suicide Prevention Center, the only community-based organization in New York City whose sole mission is preventing suicide, I want to thank the New York City Council Committee on Mental Health, its chair, Farah Lewis, and members for the opportunity to speak today. With the intense social and cultural stigma and the very real fears people in distress have about safely accessing mental health services in NYC, the need for today's hearing and, more importantly, significant action cannot be overstated. This is especially true for people of color and those living in poverty, which research shows face greater difficulty in accessing and receiving needed healthcare services than other city residents. These challenges can be overwhelming to someone who is already feeling anxious, overwhelmed, and hopeless. And then add to that the way so many NYC clinical services operate and the role of police have in responding to mental health emergencies, and a process that can be intimidating to anyone, even those with the greatest privilege and social standing, can become absolutely frightening, if not potentially life-threatening. There are no clear magic answers, and as Samaritans has advised this council for years, just adding new services and expanding others does not change the underlying issues, the structural flaws that are at the heart of NYC's helping institutions. The fact is, you cannot control how people get help. The history of suicide prevention has taught us that the more choices people have, the more options people can explore, the more likely they are to seek the help they need. But people do not seek help if they do not feel safe. They do not seek help from those they do not trust. They do not seek help when the people providing that help treat them as problems to be solved instead of the complex and dimensional individuals they are. From Samaritans' perspectives, alternatives to existing services must be supported and enhanced. Samaritans is but one example. We offer the only completely confidential crisis hotline in the city, which means no action is taken against a caller's desire, no police sent in response to their calls. This is in complete contrast to the active rescues that are initiated by most city clinical services that can result in so many unintended consequences. But instead of supporting Samaritans and other valuable community-based services with a proven record of effectiveness in reaching New York's diverse populations, the Mayor and DOHMH continue to invest in new, often unproven programs, never realizing that you can't be an alternative to yourself, no matter what the packaging and the PR. Samaritans also suggests, as we stated in council committee staff, that you can consider changing the protocol tied to 911 mental health calls, as well as the city's mobile crisis units, so that staff responding to mental health emergencies are accompanied by EMS, which have tremendous experience in handling crisis situations and do not carry firearms. Time is up. I'll send it in. I thank you. Samaritans is here to help and believes some of the needs can be addressed by our city's diverse community-based organizations.
Thank you very much. We'll next turn to Kimberly Blair, and as soon as you're unmuted by the host and the sergeant cues you, you can begin.
Time starts now.
Good morning, Chair Lewis and members of the committee. My name is Kimberly Blair, and I'm here testifying today on behalf of NAMI NYC, an organization that has provided support services for the mental health community for almost 40 years, including our peer-led, peer-run helpline, which provides emotional support, psychoeducation, and community-based referrals to callers, nearly half of whom are individuals with mental illness or family members from BIPOC communities across the city. Since the pandemic began, we have seen a twofold increase in the number of helpline calls, including a dramatic increase from parents concerned about police response to mental health crises with their children. One of the most heartbreaking calls during the pandemic came from a concerned mother calling on how best to support her son, a 23-year young Black man, after she called 911 for mental care support while her son was in distress, and instead was met by police who arrived with their guns drawn. As a result, her son fled the scene for fear of his life. He was later detained and transported to a facility for care. Although this event occurred towards the beginning of the pandemic, the mother still frequently calls our helpline to this day for different resources for her son, who has since become homeless for fears of returning to the home where the police once responded. As we know too well, the trauma associated with police response to mental health crises is not unique to this story and often has resulted in more catastrophic consequences, such as the murder of 18 Black and Brown individuals with mental illness since 2015. NAMI NYC commends council members and the PA's office for taking a step in the right direction with Intro 2210. However, it is our position that the legislation does not go far enough to remove the police entirely as mental health first responders, and therefore will not remove the trauma imposed upon Black and Brown community members experiencing mental illness. As written, almost anything could constitute as a public safety emergency, which would lead the NYPD to be dispatched, going against the goal of the proposed reform bill. For this reason, NAMI NYC would like to point the committee to the CCIT NYC Coalition's proposal for narrowly defining the term public safety emergency as when a person is causing seriously bodily harm or is wielding a weapon to harm themselves or others, and no other non-police de-escalation measures can be safely taken. Items such as a pocket knife or scissors do not constitute as a weapon. Our organization believes that this could be the best model for eliminating police response to mental health crisis in BIPOC majority communities, since the proposal was community informed. In the story I just told, the son was not harming anyone, he was simply in crisis, and as such, deserved an appropriate mental health response consisting of peers and representatives from his community, not the police. Thank you.
Thank you so much, and thank you to this entire panel. I'm going to pause briefly to see if there are any council member questions. Okay, seeing none, we can turn to the next panel, which will include Malaki Karaskila, Jasmine Bowden, Aaron Muller, and Scott Kearney. And Malaki, you can begin as soon as the sergeant cues you and you're unmuted by the host.
Time starts now.
Hello, Committee on Mental Health, Disabilities, and Addiction. My name is Malachi Karaskia, and I'm a member of the New York City Anti-Violence Project, AVP. AVP aims to end all forms of violence through advocacy, counseling, legal support, and community organizing. AVP is an organization that serves the LGBTQ and HIV-affected communities, and a membership that is predominantly Black and Brown, trans, and gender nonconforming people. We are here today to uplift that we deserve to have healthy communities. And for our community to thrive, we need systems that meet our immediate needs, like housing, education, and mental health services. There's a severe lack of mental health services for Black and Brown communities, especially the TGNC community. The few resources that do exist are not inclusive and are not culturally competent. We are in the middle of a global pandemic with a rise of hate violence, which increases the need for more mental services. My own experiences have shown the urgency of this issue for me and for others. I live alone in a subsidized apartment, and last fall, due to my deteriorating mental state, compounded with the fear and anxiety of being harassed and attacked by someone I thought was a friend, I am reluctant to admit that I attempted to flee my third-story apartment through an open window. By some miracle of God, I only suffered a sprained ankle. But can you imagine that after making it to the hospital and telling them that I jumped out of my third-story window, no one even suggested that I speak to a mental health professional? It leaves me questioning, why is it that I've asked my PCP, my case manager, and my social worker about mental health care and received no answers? It shouldn't be so difficult for me to receive the mental health care I know I deserve and would benefit me. I am still to this day struggling to access care. It begs the question, does anyone out there really care? The city must do better by prioritizing our health and safety and invest in culturally competent services that can robustly respond to the range of circumstances causing and the individuals experiencing mental health distress. One way the city can do this is by funding community-based organizations and not law enforcement. At AVP, we have a 24-hour bilingual hotline where we respond to violence and offer advocacy and counseling. There are organizations like ours that can do this work that the city can invest in, such as the Hate Violence Prevention Initiative. We urge the city to prioritize our community's health and safety, and it can start with meeting the basic needs of our community and offer mental health care that is easily accessible and inclusive of our communities. Thank you for listening and the opportunity to testify.
Thank you very much for your testimony. We'll next turn to Jasmine Newton, and you can begin as soon as the sergeant cues you.
Time starts now.
Hi, committee. Hello, Committee on Mental Health, Disability, and Addiction. My name is Jasmine, and I use she and he pronouns. I am also a member of the New York City Anti-Violence Project, AVP. I'd like to emphasize again that AVP aims to end all forms of violence through legal services, counseling, advocacy, and community organizing. AVP is an organization that serves the LGBTQ and HIV-affected communities, and a membership that is predominantly Black and Brown, and TGNC, which stands for Transgender and Non-Conforming Individuals, who live their lives and their truth, but not accepted in society. It is clear there is a lack of mental health services for Black and Brown communities, especially the TGNC community that is historically underserved. Even the resources that exist are not inclusive and not culturally competent. We're here today to uplift what we deserve, to have healthy communities, and for our communities to thrive. We need systems that meet our immediate needs, housing, education, and mental health services. A lot of walk-ins and AVPs are to seek our help and receive services. Transgender youth deal with a lot of psychological abuse and sometimes feel suicidal. Through our 27 bilingual hotline, we're able to address some of these issues and offer counseling and advocacy. There are organizations like ours that can do this work, which the city can invest in, such as the Hate Violence Prevention Initiative. The city must do better and prioritize our health and safety and invest in culturally competent services and community-based organizations and not law enforcement. We see the radical disparities when it comes to receiving care and see people who are struggling with mental health that feel isolated and alone. We urge the city to prioritize our community's health needs and offer mental health care that is easily accessible and inclusive to our communities. Thank you for listening to my testimony and for the opportunity to testify.
Thank you so much. And we'll next turn to Aaron Muller. And Aaron, you can begin as soon as the sergeant cues you.
Time starts now.
Thank you, Chair Lewis, for this opportunity, and good morning to everyone in their respective places. I'm here today to testify as a mental health provider, advocate, and speaker. My name is Aaron Muller. I'm a licensed clinical social worker and owner of a private practice alongside my wife, Dr. Trudy Ann Gale. Our hopes in opening our practice, we wanted to shift the narrative of mental health in Black and Brown communities. We have serviced over 4,000 clients since our opening in 2016, a majority being persons of color. There are clients that we're not able to service due to systemic barriers. As a resident of Southeast Queens, there's an absence of mental health agency in our area. This is a grave absence for our community. I use my social media platform to provide education and resources about mental health and stigma. With this, I received a notable amount of messages and thank yous for providing resources and support. I also refer them to other clinicians. However, there is a need for a bigger, more robust mental health system for persons of color in New York City. I'm wondering how the city can continue to push the conversation and narrative around stigma, how beneficial this can be. I would love to see a relaunch and push for Brothers Thrive and Sisters Thrive, which I facilitated 2 conversations on Jamaica Avenue and Hostos College, and it was received very well. My suggestion is to have more clinicians of color involved in outreach and engaging persons of color in mental health. Thank you.
Thank you so much. And we'll next turn to Scott Kearney, and you can begin as soon as the sergeant cues you.
Time starts now.
Mr. Kearney, if you could accept the unmute, and also if you'd like to turn your camera vertically, you're showing up sideways.
Muted.
You're unmuted now.
Okay, I'm sorry about the camera. Can I go?
Yes.
Okay, thank you very much. Okay, there's 300,000 workers, civil servants. If 1 in 5, the statistic of 1 in 5 have mental illness, you have 60,000 potential mentally ill civil servants. I was a civil servant and I was dismissed. I was an employee at New York City Parks for over 30 years. I was diagnosed with ADD, bipolar, ADHD. Some accommodations recommended by my neurologist and psychiatrist were made. The most important one, to reduce my distraction, my agitation, my irritability because of my conditions, was an office. Not giving me an office, I feel, was discriminatory and provided harassment. And it really stopped me from doing the important work that I was doing without any accommodations that should have been made. What happens is very often your supervisors and management have more authority over your accommodations than your neurologist and psychiatrist. This shouldn't be. By law, you are required to provide the accommodations in an office, and they're not always done. So I believe that, by the way, it's Equal Employment Opportunity Commission, state and city human rights departments, and of course the ADA require accommodations for mental health disabilities. The management and administrations of our agencies, I think, have far too much latitude when they can override the accommodations of a psychiatrist and neurologist. When you take away or don't provide an accommodation, legally, it becomes constructive dismission, and that turns into wrongful termination, which essentially is firing a civil servant. You can't do that. If an accommodation is recommended by a reasonable recommendation that doesn't do untold harm to the office or their management, you must give it to the employee. That may not be the case. There needs to be closer cooperation between all of your agencies, all 300,000 civil servants, and health and hospitals, or whatever kind of organization is required to have the oversight that's needed. Constructive discharge or dismissal is a very serious charge. If you don't give somebody the accommodation, you are essentially doing constructive discharge, which is firing a civil servant.
Time
They must
expired.
provide. Thanks.
Thank you very much. And thank you to this entire panel. I'm going to pause briefly now to see if there are any council member questions.
Sarah, I don't have a question, but I just wanted to thank Malachi for his courage and for sharing his personal story today and for advocating and testifying today. I just wanted to thank everyone who testified today. This information is definitely helpful, and I just wanted to say thank you.
Thank you, Chair. We'll turn to our next panel now, which includes Peggy Herrera, Ruth Lowenkron, Felix Guzman, Joyce Kendrick, and Yao Ching. Peggy, you can begin as soon as the sergeant cues you.
Time starts now.
Hi, can you hear me?
Yes, we can hear you.
Okay, hold on 1 minute. I'm sorry, I'm at work. But I'm ready. Okay, first I want to say thank you. Thank you for the opportunity to testify today. Thank you to Chair Lewis and the committee members. Good morning to everyone. My name is Peggy Herrera. I am a member and leader of Freedom Agenda and a mental health advocate. I am a mother of a son who struggles with mental health issues. On August 25th, 2019, I was arrested when I called for help for my son during a crisis, and the police showed up first instead of a mental health or the medical professionals. Instead of being helped, I was arrested, and my son never received the help he needed. It is ridiculous that a mother be criminalized for calling for help. That day, I stood in my doorway and prevented the police from coming into my house to interact with my son because I know how that has gone before for other members. People with mental health illnesses are 16 times more likely to be killed during a police encounter. Police cannot help us in a crisis because they are too busy criminalizing us, especially the Black and Brown community. Police don't take time to find out what happened before the crisis. Now in times when my son is facing a crisis and he needs to stay in his room where he feels safe, I need a safe place to stay instead of sleeping in my car. We know that there are other ways to do this. The STAR program in Denver and the CAHOOTS program in Oregon seem to be working. And here in New York City, we still have people dying. Mental health is a medical issue, not a police issue. But it's not just the crisis response system that has failed my son. It is the entire mental health system, or really lack of mental health system. As an advocate for my son, my biggest challenge is lack of resources. And when I reflect on it, I realize that it has always been the barrier to my son getting what he needs. Years ago, my son deserved a school system that offered him counselors and services to respond to behaviors that stem from trauma. As a young man whose trauma has been compounded by being criminalized so often, he needs access to unlimited mental health resources. My son should never worry about the amount of visits because no one can determine the amount of times he will have a crisis. We need a mental health system that will address and treat individuals before their actions and behaviors provoke a police response. We need a supportive and safe response. We need long-term mental health services that can offer coping skills, behavior management, social services, supportive housing, educational trades, and employment. When you give people what they need, you are telling them that they matter. We cannot continue to rely on emergency rooms or jails as mental health centers. We are facing a mental health crisis. Mental health is real. I demand that we get what we need for our families. And I just want to say thank you to Jamani for addressing our youth, because crime is a cry for help. When someone commits a crime, they're crying for help. And every person who stands before a judge needs to be evaluated. Every person, especially more now than ever. And for telehealth, okay. Thank you. I'll send the rest in.
Thank you very much. And we'll next turn to Ruth Lowenkron, and you can begin as soon as the sergeant cues you.
Time starts now.
Thank you. Good afternoon, council members. Appreciate the opportunity to talk before you. My name is Ruth Lowenkron. I'm the director of the Disability Justice Program at New York Lawyers for the Public Interest. We advocate broadly in the area of disabilities, including in all realms of mental health issues. But I too am going to concentrate on what Peggy Herrera so aptly called the crisis of mental health crises. And I join my colleagues from the CCIT-NYC, the Correct Crisis Intervention Today, New York City Coalition, which consists of over 80 organizational members. We're all about transforming what is happening in this city to respond to mental health crises. As Chair Lewis mentioned, there's a disproportionate number of Black and Brown individuals with mental disabilities, so you can only assume that they are disproportionately affected by the response to mental health crisis. And the numbers are not surprisingly reflecting that, but perhaps very surprisingly in how greatly so. As Kim Blair, my colleague, said, 18 individuals shot and killed at the hands of the police in the last 5 years alone, 15 of whom, more than 80%, are people who are Black or brown or other people of color. Unacceptable. It's a crisis. We've got to do something immediately. And what we see around the country is that people are responding, but New York City is not there yet. Even President Obama just tweeted yesterday, you may have seen that. This is what we need to do. We need to make more places do non-police response and get to the help of people who experience mental health crisis. What is the answer? The answer is the proposal that CCIT-NYC has of removing police entirely, having a community-run entity, utilizing peers, those with lived mental health experience, and EMTs, and responding in equal time to mental health emergencies. What is not the answer? The current iteration of Introductory Bill 2210. Police have an outsized role, an undefined sense of a public safety emergency, allowing DOHMH to do the work when we're trading off in that regard for another bureaucracy. A 30-minute response time, where does that come from when we have an 8 to 10-minute response time for any other emergencies? And what else is not the answer? And I'm very disappointed that Susan Herman is not here to hear this, though she has heard it from me many times. The Thrive pilot is also very much not the answer. It allows for an astronomical 30% of calls to go to the NYPD. All the calls go through 911, which is the NYPD. They insist on utilizing, I'm just about done, emergency medical technicians who are deeply involved in the problems of the current response. And again, a 30-minute response time, and they'll only operate 16 hours a day, as if mental health crises can be timed. So I would conclude by saying, especially during this time of COVID, I implore you, do not tarry. It's a crisis, and I can stand at the ready personally, along with my organization, New York Lawyers for the Public Interest, and CCIT-NYC, to work with you day and night to make this problem disappear. Please utilize us, and let's make this happen together. Thank you.
Thank you very much. And we'll next turn to Felix Guzman. You can begin as soon as the sergeant cues you.
Time starts now.
Greetings. My name is Felix Guzman. I'm testifying today on behalf of Correct Crisis Intervention Today, a broad coalition of mental health peers, providers, rights activists, advocates, and New Yorkers committed to racial and social justice. We launched CCIT-NYC in 2012 with the aim to end the trauma, abuse, injuries, and even violent death that people with mental health needs experience during a moment of crisis. I have lived in Crown Heights my whole life. My path into the mental health and criminal justice system started when I was viciously mugged into unconsciousness at age 14. The resulting trauma, which was never addressed, influenced many of the poor decisions that followed, including using drugs and trying to earn money through illegal means. My full story would require over 2 hours to tell, not 3 minutes, so I will summarize my experience, which is some of it is quite common to many Black and brown men. After 2 convictions for possession, I spent 3 years in jail, over a year in the shelter system, attempted suicide, and I've been subject to numerous wellness checks by police with riot shields. While I was diagnosed with different types of mental illness and put on numerous medications. Follow-up care consisted of a referral to Medicaid Mill in downtown Brooklyn, where staff and clients openly exchanged drugs. At the same time, I managed to secure my associate's degree, had a child, and held a full-time job for a human service agency before stress resulted in a nervous breakdown. My life began to change 3 years ago when I connected with support services following a stay at community accesses peer staff respite center. I became active in the mental health advocacy movement, which has given my life a genuine purpose and helped me to understand more fully my own circumstances. In 2019, I entered Howie the Heart peer training program, which I graduated this month after a year of remote learning, and in 2020 began working full-time for NYC Well as a peer sports specialist. My future goals include expanding my advocacy activities and finishing college to become a poetry therapist. I believe my life would have been much different if I had been able to connect with counseling services following the vicious attack when I was a 14-year-old boy. Instead, the police filed a report and my family sent me back to school the very next day. The city can take some basic steps to lessen the burden of trauma experienced daily by thousands of young people and adults in our Black and brown communities. First, the NYPD should not be doing wellness checks that involve mental health issues or responding to any mental health related 911 calls. If trained peer counselors had intervened years ago, my journey would have been much different. CCIT NYC has developed a peer informed crisis response proposal that should be implemented as soon as possible. Second, police officers often are first responders and they have valuable information about the victims of many violent incidents, including mental health related crisis calls. This information needs to be shared with trained crisis counselors for potential follow-up, which could include a phone call from NYC Well to see how the family is doing and to offer referral information. Creating a database like this is consistent with recommendations made to the mayor's office 4 years ago by the Council of State Governments Justice Center. Third, the city needs to engage and support community organizations and other key stakeholders based on the principle of asset-based community development. This approach focuses on community strengths and non-traditional support networks. This idea was proposed to the city in 2018 as the recommendations of the Mayor's Task Force on Crisis Prevention and Response. Called Neighborhood Support Networks, it recognized that the knowledge and skills of local groups could be harnessed to support high-risk people that are well-known to residents. The city... I'm going to go ahead and just try to finish up. Just be a few seconds. The city cannot form these networks on its own and needs to outsource the organizing effort to a group that has this special skill set and that provides supplemental contracts to local groups. Finally, building on the first two recommendations, the city should also expand the implementation of community-based health centers. Modeled after district health centers from the 1920s, the city's Department of Health in 2017 established 3 neighborhood health action centers in high-need communities to provide place-based services that respond to the social determinants of health. The action centers provide low-cost office space to co-locate partner organizations, allowing residents to access a broader range of services than the health department could ever offer alone. Thank you for allowing me to share my story. It's important to stress that my experience is not unique. Childhood trauma and its aftermath is directly to a range of negative outcomes, including poor educational attainment, higher rates of incarceration, high-risk behavior, depression, anxiety, and early death. The impact of trauma is especially pronounced in low-income Black and brown communities. For my family, a phone call to let us know that someone cared and to offer information on how and where to get some help could have made all the difference in the world. I thank you for allowing me to share. Thank you.
Thank you so much for your testimony. Our next panelist will be Joyce Kendrick. And Joyce, you can begin as soon as the sergeant cues you.
Time starts now.
My name is Joyce Kendrick, and I am the attorney in charge of the mental health representation team of the criminal defense practice at Brooklyn Defender Services. Thank you, Chair Lewis, for holding this important hearing on access to mental health care in communities of color. The mental health representation team at Brooklyn Defender Services works to support people living with serious mental illness who have been accused of a crime in Brooklyn. In response to the question from Councilmember Rosenthal, there are mental health courts in every borough. Every mentally ill client can be referred to mental health court in lieu of having their case proceed on the traditional track. In mental health court, the client is assessed and an individual treatment plan is devised. The goal is that after successful completion of the mandate, the client would have been connected to services in the community and will be able to continue to access treatment and support. I have witnessed amazing outcomes for these clients. That said, the court often mandates mental health care for people who could have avoided the criminal legal system involvement altogether. The city cannot rely on the NYPD and criminal legal system to address mental illness. It is a fact that individuals experiencing a mental health crisis are more likely to be engaged by police than medical providers. This involvement of police too often leads to disastrous consequences for the person that help was summoned for, particularly for New Yorkers of color. Having a mental illness is not a crime, and New York City must invest in mental health response teams that de-escalate crisis and prevent people with serious mental illness from entering the criminal legal system. We urge the city to invest in free and low-cost mental health services that are designed for people who have experienced hardship, trauma, and incarceration. These programs must be equipped to meet the needs of people who are newly being introduced to mental health care to create a familiar, non-threatening therapeutic environment for those who may be hesitant to engage in treatment. Such programs must employ trained clinicians who are fluent in multiple languages. We must not place the burden on the patient to educate the clinician about the realities of incarceration, gun violence, or racism. Thank you again for your time.
Thank you so much. And our next panelist will be Yao Chong. Yao, you can begin as soon as the sergeant cues you.
Time starts now.
Sorry about that. Hello. Good afternoon, committee chairs on mental health, disabilities, and addiction. My name is Yao Chang, and I am a staff member in the Community Organizing and Public Advocacy Department at the New York City Anti-Violence Project. Our mission is to empower lesbian, gay, bisexual, transgender, queer, and HIV-affected communities and allies to end all forms of violence through community organizing, education, counseling, legal services, and advocacy. Our active membership is predominantly Black and Brown, trans, and gender non-conforming people. I'm here today to assert that the communities that we serve, collaborate, and build relationships with deserve to not just have their immediate needs met, including housing, education, food, shelter, and mental health services, but to thrive. Mental health is crucial for sustainable and overall well-being for Black and Brown communities, which have been historically underserved even prior to the pandemic. As folks have mentioned, the COVID-19 pandemic is causing a mental health crisis. Majority of the services currently available are not culturally competent and unequipped to adequately support Black and Brown, trans, and gender nonconforming people who, in addition to experiencing the pandemic's consequences, including eviction, unemployment, food insecurity, mental distress, and more, are also facing increased hate violence. Throughout the pandemic, the New York City Anti-Violence Project has continued to provide programming for peer support, our services mentioned before, including our 24 English and Spanish hotline, 24 hours hotline to Black and Brown TGNC people. As staff that is fortunate to co-create a space of leadership development and camaraderie with our community members, I've really seen the importance of relationships and services that affirms Black and Brown TGNC people's identities, experiences, and traumas. However, we are limited in our resources. We know that there's much greater need than supply. Additionally, from my personal experience in psychiatric units due to my own mental health and survivorship from queer intimate partner violence, I have witnessed how the current mental health system enforces anti-Black racism and ropes patients into costly care that is often more pathologizing than helpful. Therefore, the city needs to prioritize funding adequate mental health resources, services, and infrastructure over policing for our communities. If the needs and experiences of our city's most impacted residents are centered, the city will be stronger and better for all of us. The city can do this by investing in community-based organizations like ours, which has a variety of programs and initiatives that address the root causes of violence against Black and Brown, trans, and gender nonconforming people. This includes our hate violence prevention initiative. I believe the city has the power and opportunity to invest in our community's health and safety and emerge from the pandemic with a worthwhile legacy. We call on the city to do so and to ensure that the services provided to our communities are accessible and inclusive. Thank you for giving me the opportunity to testify.
Thank you so much. And at this time, I'd like to mention that if we inadvertently missed anyone who wanted to testify, please use the Zoom raise hand function. And I also wanted to remind everyone that you can submit written testimony to testimony@council.nyc.gov. I'm just going to pause here to see if we've missed anyone. Okay, seeing none, I'm going to turn back to Chair Lewis for any closing remarks and to close out the hearing.
I just want to thank everyone for testifying, for sharing their personal testimonies, and for all the advocates and CBO leaders that are here today. Definitely took some notes, got some information and recommendations, and we'll definitely include you all in anything that we do moving forward. And with that, I want to close out this hearing. Thank you so much.